एक मुखिया है क्या?
हाँ,
और एक मुखिया है लगता है।
नहीं नहीं, अभी तक तो नहीं दिख रही है मुझे तो।
क्या है चालू?
हाँ,
क्या है चालू?
ओके ओके, थैंक यू. Now let us look at a clinical scenario that a 58-year-old retired Major General complained of severe joint pain and swelling at the base of first metatarsophalangeal joint. Remember, the pain is at the base of the first metatarsophalangeal joint, and he was a non-vegetarian and chronic alcoholic, and he denied any trauma to the toe. On examination, he had mild fever, and the right big toe was swollen, warm, and red, which is a sign of inflammation. Lab investigation showed serum uric acid of 12 milligram per deciliter, which is increased. Normal range of uric acid is 3 to 7 milligram per deciliter. So the diagnosis of this clinical case is gout, because the pathognomic feature of the uric acid increase is the pain in the first metatarsophalangeal joint, that is big toe, and the patient was a non-vegetarian. Non-vegetarian food is rich in purines, because of which there is increase in the uric acid, and alcoholic, as we know that alcohol aggravates the gouty pain and leads to increase in the uric acid. And there was no history of trauma, ruling out further diagnosis of gout. And also there was sign of inflammation and uric acid level were increased. Now what is gout? Gout is associated with hyperuricemia, and there is accumulation of urate crystal in the synovial fluid of the joint, leading to inflammation and acute arthritis. It occurs predominantly in males, and it is common in middle-aged early men and postmenopausal women. Toffee, that is the urate crystals which are deposited in the joint, is called as toffee because of the formation of toffee like structure in the joint. It is most commonly seen in distal joint of the foot, which is cooler area of the body. So low pH acidic environment and low temperature favors urate crystal formation. Now let us look at the causes of gout. It could be either primary cause, that is primary gout, or it could be because of some secondary causes called as secondary gout. So in primary gout, the causes could be abnormal PRPP synthetase enzyme, abnormal glutamine PRPP aminotransferase enzyme, deficiency of HGPRTase, deficiency of glucose 6 phosphatase, and glutathione reductase variant. Secondary gout leads to formation of uric acid. Secondary gout could be because of increased formation of uric acid, that could be due to leukemia, lymphoma, or polycythemia. There could be increase in the tissue breakdown or trauma or increased catabolism in situations like starvation. Uric acid excretion decreases in 90% of the cases. It could be in renal failure or patient with thiazide diuretics, patients of lactic acidosis and ketoacidosis. Now let us talk about the primary gout and the causes. So 10% of the primary gout is idiopathic and it may show familial incidence, and it is more common in male. Incidence is 1 is to 500, and there is increase in the synthesis of uric acid and purine nucleotide. As we have seen that there could be abnormal PRPP synthetase enzyme, because of which there is going to be more synthesis of uric acid because of increased formation of nucleotides. Similarly, with glutamine PRPP aminotransferase, deficiency of AGPRTase enzyme, because in AGPRTase deficiency, what is going to happen that the guanine is leading to the formation of uric acid, and also the PRPP, which is not utilized in this process, is going to increase the production of purines. Glucose 6 phosphatase deficiency, which happens in von Gerg's disease, and glutathione reductase variant. Now we'll talk about the glucose 6 phosphatase deficiency, that is in von Gerg's disease. What happens that glucose 6 phosphate enters the HMP shunt to produce excess ribose 5 phosphate and PRPP, which leads to overproduction of the purine. Okay. Now, the lactic acidosis in von Gog's disease impairs the uric acid excretion since it competes with the excretion of the uric acid. Okay. So, increase in glucose 6 phosphate, because the glucose 6 phosphatase enzyme is deficient, the excess glucose 6 phosphate will enter the HMP shunt. HMP shunt increase will lead to formation of more ribose 5 phosphate, which will in turn increase the purine biosynthesis, which in turn will produce more uric acid, leading to gout. Similarly, the excess glucose 6 phosphate will enter the glycolysis. This glycolysis under anaerobic condition will form lactic acidosis, leading to uric acid reabsorption and hence impairing the uric acid excretion. Now, the elevated glutathione reductase variant, what it does, that it converts oxidized glutathione to reduced form of glutathione by utilizing NADPH from the HMP shunt. Now, due to abnormal activity of the glutathione reductase, there is increased NADP plus. So, this increased NADP plus increases HMP shunt, ultimately leading to formation of more ribose 5 phosphate, more ribose phosphate, and PRPP synthesis will lead to overproduction of purine, hence increase in the uric acid formation. Now let us look at the summary. This glucose 6 phosphate leads to formation of glucose via glucose 6 phosphatase enzyme. In von Gog's disease, this enzyme is deficient. So there is more glucose 6 phosphate which enters the HMP shunt, leading to formation of more ribose 5 phosphate and more NADP plus because of the increased glutathione reductase activity and increased PRPP synthetase enzyme, leading to formation of more purines and hence more uric acid formation takes place, leading to increase in the uric acid formation. So this is the summary of the uric acid increase in gout with different causes. Now coming into secondary gout, as I've stated earlier, it could be because of increase in the formation or decrease excretion. The symptoms of gout that we need to remember is because of the deposition of sodium urate crystal in joints, leading to inflammation. Toffee, as I've said, the cluster of urate crystal in soft tissues, distal joints. Gouty arthritis, that is deposition of urate in kidney tubules, leading to renal failure. Now the precipitating event in the gout is infection. Any surgery, any stressor, especially alcohol, aggravates gout. In the university examination, the most common reasoning question which is asked is how alcohol aggravates gout. And the patient will always have a chief complaint or maybe the history of consuming alcohol overnight and suddenly waking up with pain in the great toe. Okay, so that is where the diagnosis of gout is going to be taken. Precipitating factor for gouty attacks we have already discussed, that is high protein diet and alcohol. Why alcohol aggravates gout? Now look at the reason. The ethanol gets converted to acetaldehyde, which gets converted to acetic acid utilizing alcohol dehydrogenase and aldehyde dehydrogenase, converting NAD plus to NADH plus. This NADH favors conversion of pyruvate to lactate, increasing the production of lactate. Okay, so this increased lactate leads to acidosis, which leads to decrease in the pH, which favors the precipitation of urate crystal, and also this increased lactate competes with the excretion of uric acid at renal tubules. Now coming into the lab investigation, we have already discussed more than 7 would be the uric acid in males and more than 6 in female. On X-ray, we'll see deposition of sodium urate crystals, gout erosion and soft tissue calcification. On polarizing light microscopy, sodium urate crystal is going to be seen in joint synovial fluid. Gout crystal is going to be needle shaped and negative birefringent. The management of gout is via NSAIDs for acute relief of pain, acute inflammatory corticosteroid, colchicine, which is outdated at present. It is prevented via colchicine, allopurinol and probenecid. Probenecid is a uricosuric drug, means it increases the excretion of uric acid. Pegloticase is recombinant uricase. Now, the dietary management is restriction of non-vegetarian diet, especially red meat and shellfish, which is rich in purine, and also alcohol, especially beer, which is rich in purines as compared to whiskey or any other form of alcohol. Now, how allopurinol helps in the management of gout? Basically, allopurinol is a competitive inhibitor of xanthine oxidase, and it is a drug of choice for treatment of gout. The latest drug for treatment of gout is febuxostat. Okay, so as we can see that it is a structural analog of hypoxanthine. It competitively inhibits this enzyme, and initially it is a competitive inhibition, later it becomes suicide inhibition. Okay, and hypoxanthine and xanthine are more soluble and excreted in urine easily. That is about gout. Remember that gout is important from university point of view, from MCQ point of view, and from clinical cases, as well as reasoning question is asked from the gout. Okay, thank you. कंप्लीट किया, क्लोज कर देंगे.